Hello, everybody. Dimitrios Kostopoulos here from Hands-On Diagnostics, and this is the number 6 event of the 2021 Strategic Planning Series. We have covered several subjects. Today, we will be discussing about compliance. Now, compliance in a practice is something that is extremely important. Those of you who may be running organizationally in your practice, a 7-division organizing board, your division 5 is quality assurance division, quality control division. Under that division, under quality control, you have areas of compliance. Also, compliance can be part of your division 7, which is, your owner's division or the executive division. Now, those of you who have no idea what I'm talking about when I'm referring to a 7-division organizing board, anyhow, in any practice that you have, you must have fundamental things of compliance. Compliance can be costly in the short term if you apply it, but it will be very, very, very costly in the long term if you do not apply it. What I mean costly in the short term, when you create compliance guidelines, they may cost you a little bit to put them in place. But if you don't, it can become a very expensive proposition in the long term that can really put your organization in danger. Now, we believe that part of your strategy should be for 2021, should be how for your organization to become even more compliant than it was before, and how you can adhere to different guidelines in the so many different areas that we are dealing with, especially after or during, I should say, this pandemic. Now, to discuss this issue, we have no other than the absolutely expert on compliance, who is the president and CEO of the Business and Clinical Management Services, Mary Daulong, our very good friend, who she looks extremely young and youthful, as you can see, but she has many years of experience in this area, and she's been working in the area of compliance since when? Mid-90s or so, Mary? What's the time that you started in the compliance?
1985.
Wow. Okay, good. That is awesome.
There are people on the phone that are in the meeting that probably weren't alive then.
That is possible. That is possible. But anyway, guys, what I have asked Mary to do today for us is, in order to keep this a little bit more interactive, I have asked her just to spend a little bit of time on discussing some issues from her own initiative, and then to open this to questions, because there are so many different areas of compliance, especially applicable to 2021, that each of us may have different type of questions and different type of issues to discuss. So Mary, thank you for joining us today. I'm going to turn it over to you, and let's start with at least some basic information or the newest data that you may have that we need to know right now.
Absolutely. In fact, I was telling Demi right before we started that 15 hours ago, CDC just released pretty breaking news, and this is a constant situation for us during this pandemic. As you know, I guess on Tuesday we sent out our update newsletter, which is an e-newsletter, and we did a frequently asked questions on immunity and transmission. And had I had this information, it could have just been out there. So it's one of the things about compliance is to know your resource and to know that it's valid and has been vetted. There are a lot of people that we we try to rely on, and you just want to make sure that your compliance resources and consultants and whatever are valid. One thing we experience as people trying to be compliant is that sometimes we get multiple answers for the same question, and that does not that does not exclude rather the federal government. You know, I kind of say, ask them once, get an answer, ask them twice, get a different answer, ask them a third time, and hopefully it reinforces one of the two. And it's because there are so many things going on, not that people would are inept or intentionally would, you know, deceive you, but it's important again to reinforce that. During the pandemic, we had some waivers that relaxed a few things for HIPAA and for OSHA and for Medicare in particular, as far as provider audits. So let's just touch base on what's happening right now. As far as HIPAA, the Office of Civil Rights, who is the oversight, investigation, and organization for HIPAA, has stated very clearly that there have been a number of complaints and findings about the lack of business associate agreements. Those are mandated, so they have to be in place. So we're talking about dealing with vendors, anyone who deals with your PHI or EPHI. So that's a biggie. They are also going in with a red light looking for security risk analysis. Those are required initially to evaluate your facility's vulnerabilities as it has to do with electronic protected health information. And then you have to update them as things change. And they are citing, and we're talking about big dollars, citing practitioners, not just large healthcare organizations or hospitals, but we're seeing more and more practitioners being cited, fined, penalized. It's not a fun thing, and those dollars mount quickly. So those are the two main areas we are seeing for HIPAA. For OSHA, they relaxed not the standards, but some of the reporting requirements. Now they're going back now and saying, oh yes, you do have to report. You do have to use certain forms if there are injuries or exposures, those types of things. Now, physical therapy has an exemption. And we do not, except in California, I believe that's the only state, but I'll have to verify that, do not have to use that form to report non-life threatening injuries or exposures. We have to certainly, if there is a major life threatening or death, God forbid, as a result of an activity in your clinic, you would definitely have to report that to OSHA. But we are exempt for that particular provision. Now they are really stepping up infection control, which typically falls under the exposure control standard, and that's where you find bloodborne pathogens. They were mandated by the new president to address a standard for COVID. And they had to decide whether it was necessary by last week. They did determine it was necessary, and the standard is being developed and will be released March 15th. Now, it states clearly that this is for all industries except healthcare, because healthcare already has standards in which we comply with. Plus, there have been very specific guidances along the way through the pandemic. But that doesn't mean you're scot-free. If you haven't implemented an emergency um, preparation plan and protection plan that deals with that, you have some problems. If your state, and there are 14 of them, that have now state emergency safety plan requirements, you have to meet those. We prepared a very lengthy, um, well, I'm going to say lengthy, it's short compared to some of the things we do, but about an 8-pager that really walks through what happened, what we've done, what your clinic has done, what protections we take for patients, employees, and so on, with a number of support documents. These are the kinds of things you're looking for. Many of you have been very, very creative in really outlining or even detailing every step, from how you wash your hands to what kind of screening you do to what signs you're posting, social distancing, all of that. And that's what's necessary. It is a very, it should be a very, very specific, facility specific document. So very important as it relates to OSHA, and do look for that standard. And unless I'm mistaken, we won't see it addressing us in healthcare, but we'll probably be, right there behind them with some kind of statements that, well, this might apply and that might apply. And there are some very good things that they have on their list to address, such as how and when or if you offer and pay for vaccines, how you handle absentees due to post-vaccination side effects, those types of things. So if you're interested in seeing that information, you can always contact us at BCMS. And so, of course, I'd be amiss if I didn't talk about what's happening in the world of audits being performed by Medicare and other payers. We certainly have seen some commercial payers um, step up their activity, mostly, I think, as a measure to keep us on our toes. Although the results, if we're not documenting right, if we're not billing right, if we're not complying with their policies as they relate to telehealth, then there are issues. Medicare, on the other hand, did put a hold on audits, clinical and billing audits as it relates to us back in mid 2020. However, in August, or maybe it was earlier than that, probably the second quarter of the year. Um, in August, they said, okay, y'all can start again. And NGS was the first one out, out of the gate with aggression. We have a number of clients in New York, and we got calls daily. Oh my God, they're starting again. Now, they are post payment audits, they are not TPE audits. The TPE was, quote, supposed to be a review educational experience, but it's turned out to be years of being a pen pal with Medicare, going back and forth with documents, with audits, with educational things. They put those on hold. I haven't seen any of the contractors in any of the states implement TPE audits, but the post payments are pretty aggressive with NGS, First Coast in the Florida area, and Meridian. Specific to California, and then even more specific rehab agencies. Other than that, I haven't seen a great amount of work, but NGS has been the most active. And,
Mary,
uh-huh.
also, sorry interrupting you, also for those people, just to make sure that we're not saying sometimes words that people do not fully understand if
And
they don't have too much experience on that. Can you describe what, with more details, what a post-payment audit is and what usually a carrier is looking at
okay.
on a post-payment audit?
Sure, sure. I'm sorry. And also, I'm using some abbreviations. NGS is Natural Government Services. It's a contractor um, that works with Medicare, and they handle our payments, our enrollment, all of those things, our audits. So when we look at it, there are several different kinds of audits, or not several, many different types of audits. But a post-payment audit is exactly that. You have been paid, and the payer is going to go back and say, I would like this date of service, this date of service. Typically, they do as few as 5 and as many as 40 requests for records. The confusing thing is when you get the letter and they list the date of service, many providers will send in that date of service only. Well, the problem is with our treatment encounter notes, so let's just say it's not an evaluation day or a progress report day. It is a day that you've done your daily notes, does not substantiate medical necessity. So they expect to get all of your records as far as evaluations, progress reports, um, any home programs you've done, plus that date that they have requested. And how you present that information is critically important because if you leave it out, if you don't have signed plans of care, those types of things are so critical. Another thing we can make available to you is what we call our ADR package. Medicare calls this an additional documentation request. That's the ADR. And I don't know why it's called additional because they don't have any documentation to start off with. But we have a packet and it walks you through exactly what to do as far as submitting your information. And again, if you contact Alicia, we could get that information to you if you're interested. Um, I always say if you start out on the right foot with the auditor, you have a better chance. I'm not saying you can totally eliminate any errors or omissions or anything of that nature. But if you start off demonstrating consistency, organization, as well, of course, content, you have a much better chance than being disorganized, having each one of the charts um, submitted with a different style or poorly put together, poorly copied items, those types of things. It sets the stage for their attitude. So important that you remember that if you have the good fortune of being asked to submit records. I don't think you'll see prepayments right now. So prepayment audit would be, we've picked you out. Something either flagged us and we've stopped payment, or there's been some issue for us to look at, or it can be after post payment and you maybe fail that audit and there's put you on a prepayment, which means they have to read your documentation, your billing before they agree to pay you. Now that stifles cash flow like you can imagine. So you want to avoid prepayment audits to any degree that you can possibly do it. Um, and like I said, most everything right now that I'm aware of is a post-payment audit. So, Jimmy, do I need to touch base on anything else that's pressing for you, or can we open it up?
Yeah, you guys can, if there is something specific that you want to ask, you can unmute your microphones. I just want to tell you what we do as a practice, and I'm not necessarily saying that what we do is what everybody should do, but what we do as a practice is, because we want to be proactive, we are doing voluntary audits of select Medicare records. So we do it through Mary. She has a department for these audits, and they decide, let's say, to audit so many records. Now, we have two different companies. We have a company that does only physical therapy. We have a company that does diagnostic testing. So we pick up charts, the complete chart, the complete history. It can be done also electronically, in paper, whatever. And we provide that to an auditor from Mary's company, and they review this as if they were, let's say, a Medicare auditor. And they provide us with very, very valuable information and critique, and what record is kind of passing, what record is not passing, what improvements need to be made. And then we go ahead and make improvements. And I am not going to mention any other information on that, because if I mention any other information, which is now on Facebook, that is not appropriate, really.
Right.
I want to put in danger my company.
We're not marketing. I think one thing that's important, and while Demi uses our services for our offsite audit, it's critically important that you do internal audits too. And that's something that I think any group that's auditing externally for you should be offering um, tools to help you do that. So let's just say, for instance, you didn't do well on getting plans of care signed. And so what we would do is we would suggest that you do a focused audit. So uh, if we identified, we use the scorecard method in addition to the audit by therapists. So if we identify a particular therapist that this was, occurring. Now, I do know that therapists aren't typically responsible for obtaining signatures, but there you have to be accountable at the therapist level, because when your NPI goes on that claim, you're saying I should be paid for this claim. So you want that accountability there. So we usually say, okay, let's do a focus audit. Let's give everybody about a month before you start, so people can kind of get in the habit of making things happen. And then audit X number of charts internally just for signed plans of care, let's say. Or let's say that you don't meet your progress report deadlines. Then again, we would do a focus audit. Not we, the internally would be performed by the clinic, so that they can see and have the opportunity to improve. Uh, you want to have some strategy there to show that you are taking corrective action. Because if you get audited down the road, you can say, well, we have been doing internal audits, and maybe something that you build set them off. Maybe it's more frequent than your peers or something of that nature. But at least you can show that you have made a good, valiant attempt to be compliant to the best of your ability. And that goes a long way when they start dishing out fines and penalties. I will take a moment just to tell you this, since it was the breaking news from CDC. And I know we're all about fed up with COVID, but we still have to deal with it. The questions we're getting now have to do with immunity, transmission, those types of things. Um, and what CDC just released is that if you have completed your, now I'm talking about healthcare practitioners, okay, at this, well, public in general, but as it relates to you. If you have completed the two-dose series and it's greater than 2 weeks, okay, it's 2 weeks or more since your last vaccine, and you are exposed to positive COVID, you do not have to quarantine. Now, they do have certain criteria. One of them is that, again, you have the 2 week period that has to be met, no exception. There's three criteria. The 2 week period, you have to, I should look at it. I have it right here so I don't forget it. Um, I'll tell you 1 second. So I just get them real. Um, you do not have to quarantine. Again, three things. So the first is the 2 weeks. The second is within a 3 month period. So if you're out of the 3 months since your vaccine, then you would have to quarantine as the guidance provides. And the third is that you have remained asymptomatic during that period. So if those three things don't occur, you still have to quarantine as you normally would. They do not know um, how quickly we develop immunity, but they believe it's within that 2 week period after the second dose. The transmissibility is the big issue. So you still are required to wear a mask, socially distance, those types of things. All of your COVID precautionary and prevention procedures are still in place.
I will um, touch upon a little bit of a different area, and I would like you to discuss about this.
Okay.
There are a lot of people, almost every private practice owner that I talk to, who received money from the first release of HHS.
Mm-hmm.
A whole bunch of other people received more money for the second release of HHS. And just around the holidays, there were people who were received money from the third release of HHS. So from the CARES Act, right? Money. So I had a discussion with a private practice owner, and I asked the question, so what specifically are you doing in documenting how you are spending this money?
Mm-hmm.
And to my surprise, the answer I got from the specific individual was that he or she is putting the money down towards the purchase of a real estate. So I would like you to just talk a little bit about this and what might be the consequences if proper documentation for the correct use of these funds is not in place.
Well, you're going to hear this not too often from me, but I send all of that to accountants because they are the ones who can tell you exactly how you have to account for that and what are the provisions. But I will talk to the documentation part. It is just like patient care. If you don't document, it wasn't done. Amen. Bottom line. You must be very specific. This is when working with your accountant is critical because they truly understand that part far better than uh, we do from a clinical compliance type of perspective. I have heard some of the same things that people are taking funds, not dedicating them to staffing dollars, other things that are permissible under the loan. um, because the amount wasn't too significant. You know what? It's just not worth the risk. It's just like not complying with OSHA. At the bottom of the loan, it says you will comply with all standards of OSHA that apply to healthcare providers. You don't do it, they can come and take their money back. They can apply fines and penalties, and they can be significant because Medicare has you know uh, the Monetary Penalties Act. They have um, a number of fraud and abuse uh, laws that are in place, and keeping the government's money is foremost. They have provisions about you return their money if you shouldn't have gotten it. And usually that has to do with, of course, if you were paid for services you didn't deliver or were not delivered according to the conditions of coverage, those types of things. But this applies just as well. If you are using the government's money other than how it is supposed to be utilized, then you're going to be subject to not only fines and penalties and them saying you got to pay us back, um, but you could have administrative sanctions, which means they could exclude you from the program. They could they could turn it into a criminal violation. So the the ramifications are very, very severe. And I know a lot of times we think we're just a small pea in the pod. Well, if you get enough small peas in the pod, you got a big bowl of soup. So I would suggest people work closely with their accountants, make certain they are accounting for every dollar provided, and not just at their end, to verify and document exactly what's happened.
Thank you.
Mhm.
Yes, I'm getting um, several direct messages here from people that they're saying that a few people say that they are currently working um, on the compliance program with you right now.
Yay, we love that.
That's awesome. Now, Sherry, I'm trying to understand your question. Um, let me just read it.
Right.
It seems I had asked Dr. Bill about the audit process for the EHR and how it would be done. Not sure what she means totally.
Okay, so when we're looking at auditing, there are a lot of ways. Obviously, we could do the old-fashioned way, paper, but when we're looking at auditing clinical and billing records, the auditor, whoever it is, can either have a secure portal where you can um, move your documents to securely, or you can give a passcode or key or whatever it is, and the auditor can access your EMR. Of course, all of this needs to be done under a business associate agreement and should not be initiated, no exchange of any PHI before that business associate agreement is executed. That's one of the things I think our first instinct when we get a letter from Medicare that says and sometimes they say audited and sometimes they don't, but they start asking for records. The panic is send the letter to the consultant, and in that letter is PHI. Okay, so we have two issues there. We have one, we don't have a business, because that will have the names of the patient. We don't have a business associate agreement. And also, you just sent uh, PHI across an open internet, and in most cases, it is not encrypted. So we have a breach. So, we're trying to do things right. We end up having violations because of that crises reaction. So I would tell you whoever you're dealing with, but it's really a pretty simple process to go into EMRs. I know most auditors are familiar with the major EMRs that we deal with. On occasion, we run into some that have been proprietary, and they've been developed, in conjunction with maybe another entity or maybe not for PT. Those aren't so as easy to deal with, but most auditors can work around that. And again, what you would be looking for is that you get a very systematic, quantitative um, summary or detailed report on the findings and some guidance on corrective action. So hopefully that answers your question. If not, I'll be glad to discuss it further, or you can open up your mic and we can, further discuss it.
I know, Mary, that you are not directly involved with reimbursement, but just in case you have heard anything, apparently there are some complaints from therapists who are billing in Florida, Part A Medicare, and I'm reading here there is a major issue with the reimbursement delays.
Okay, all righty. So when you're talking, they're not billing, they do use a UBO forward, which is
Yes, because it's Part A.
institutional form, and rehab agencies are considered facilities, institutions. It's the most insane thing. But anyway, that's my opinion. There were certainly delays, and what happened is the folks that handle Part B 1500 forms had their act and get together a little quicker. The changes that were made at the end of the year, right before we kicked off in January to the cuts, um, the sequestration not going through, all of those things mean they have to adjust their system, their edits. The same thing is they had to adjust the edits for the CCI, the use of the 59 modifier to bypass paired codes. So they had a lot of changes. And when you look at institutional billing, they're dealing with hospitals, they're dealing with, your non-outpatient facilities more so. So that's probably was a priority. And unfortunately, our rehab agencies were probably secondary. I'm not sure of that, but that's my guess. And we have heard that not just in Florida.
I see. Okay. All right. Mary, anything else from you?
I don't think so. Again, the thing I want to reinforce is any endeavor you make to be compliant is a positive. If the federal government, if commercial payers, whomever, if it's OSHA, if it's HIPAA, it makes a difference to see that you have made endeavors. They may not be perfect, but you've made endeavors and that you've tried to take corrective action when you have identified deficiencies and you've documented and train, train, train. There's so many educational tools out there. We certainly have webinars, but you can look and find reputable sources out there to help you with staff education. And that is critical because that is one of the 7 steps of compliance is education. You have to have somebody who leads it all. So you have an officer of some sort, and you have to identify and develop policies and procedures. But policies and procedures are only as good as the people who understand them and know them. And so that's critically important that you demonstrate that every time you meet about any type of compliance thing. regardless of how small you think it is, document it. Note who was in attendance, signatures, those types of things. So anything you can do to show that you're making endeavors would be a positive.
Thank you, Mary. Thank you very much. Actually, I'm getting here a question from someone. I haven't reported the first HHS. When is that due? I mean, I don't know if you have the question, the answer
What
ready.
was the question? What was
When the reporting, because you have to go to the HHS website at the portal, and you have to say that you did receive the funds. You have to test it, attest that you got the funds.
Right.
I suggest that you go to the HHS website and look at the deadlines there.
Right.
Without attesting that you received the first batch of money, they're not going to give you any additional money.
Absolutely.
And for this batch of money that they're giving right now, actually there was an application deadline that had to be submitted, I think sometime in October. Let me ask real quick here, if you just type the word yes, if you have received any money from the third release, and if you did receive it, you should have received it somewhere around the third week of December or after that. Anybody on this call has received? Okay, so nobody has received yet. I just want to let you guys know, I spoke with HHS yesterday, and they told me that the applications that they received towards the end of the application period, they started reviewing them in mid-January. Okay, so you may, Graham says he was denied. So Graham, you got an actual denial or you got just no response? What did you get?
I got a physical denial, Dini, that said that our industry or my office or my location, I forget the exact verbiage, was not eligible for this third round. We received funds in the first round, but the third round, there was an outright denial.
Okay, Graham, we can chat later about that. Do me a favor, just forward to me a copy of that, because in my opinion, this should be disputable. And disputed, because I can name to you at least 6 or 7 practices who I know they received money in the third round of HHS funding at significant multiples. Bob, you send that to me too, please. I want to look at that. There are specific guidelines. You had to be able to support it financially by sending them, your financials, right? But
yes.
The industry as an industry was not excluded.
Right. Okay. Yeah, I was aware there were other practices that were receiving it. So, yeah. Okay. Thank you.
All right. No problem. All right. Mary, I want to thank you so much for joining us on this and providing great enlightenment on compliance. We appreciate your help.
Super, my pleasure. My pleasure.
Awesome. And to everybody else, thank you for joining us today.